Hello and welcome to this video on SACT service delivery and virtual clinics. We do hope that you find it useful. Please do share your thoughts in the comment section and make sure that you like and subscribe so that you don't miss any new content that we upload. It is now my pleasure to introduce Elaine Tomlins, who is a consultant chemotherapy nurse from the University Hospital Southampton NHS Foundation Trust.
Thank you. Well, thank you to SBK and to Sanofi for asking me to speak today. I am no expert on this subject. I was asked to talk about our experiences in Southampton, and I hope that I'll be able to generate some thoughts and some debate as we go through. So it's not an experience really what I've got to present. So this is the dreaded COVID that we've all been working through through the summer, and certainly has impacted on the way we deliver our cancer services and the way patients access our hospitals. So what I'm going to talk about is the impact in oncology, what COVID-19 has meant to cancer services, what we need to think about as we ramp up the services. Ramping up is one of those phrases that you tune into, don't you, when the politicians are talking, and really highlights things, and a little bit about the workforce. So my background is chemotherapy, SACT, immunotherapy treatment really for cancer services, and that's mainly what I will be talking about. But I do have some thoughts around surgery and how we get patients back into our clinics. So at the beginning of the pandemic, before we went into lockdown, we all sat down in our hospital and thought about what do we need to do. In Southampton, we were planning to be a surge hospital because we have a big university population, we have a transient holiday population as people come to the South Coast, and we also have a big cruise line industry. And so we planned to be a surge hospital, but from a cancer services point of view, we really wanted to make sure that we were able to provide treatment for all those that needed it. And that was our overarching goal, and how were we going to make that happen? And I'm pleased to say we did make it happen for all those that needed it, with lots of adjustments, as I'm sure most of you experienced. So, as I said, the plan to be the surge hospital really overtook everything, and actually, in reality, we overplanned, as I'm sure many of you did in the big hospitals. Certainly, we never breached our critical care footprint in terms of treating or accepting COVID patients. And although we split our hospital into two to be a hot and a cold site, actually everybody stayed within the ITU critical care theatres environment. So a lot of the planning that we did actually didn't materialise. But we didn't know that at the time, and we're going into potentially a second wave with learning from that, and with more thoughts about how cancer patients have managed through the summer. So this is what we did really in terms of how we manage the treatment pathway, or the whole cancer pathway, really. I'm sure you'll recognise some of this. So just the grey boxes: diagnosis, surgery, chemotherapy, radiotherapy. So as far as the diagnostics were concerned, of course, many of the screening programs were cancelled or postponed, and this caused a great deal of anxiety, particularly for primary care. The 2-week wait plans were still in place, but again, our numbers dropped significantly. And one of the metrics that we heard at the time was that there were 5% more 5% positive cancer biopsies in comparison to last year. So if last year was 100%, we were now down at 5%. So people weren't coming forward, and we weren't diagnosing cancer. We also had to make sure that there was no aerosol generating procedures going on, and there was a debate about whether endoscopy was an aerosol generating procedure as a diagnostic test. And from a patient point of view, there was a view that the GP was closed. Now, the GPs argued vehemently that they weren't closed, they were just working differently. But for many people, there was this notion that the GP was closed and they couldn't get an appointment. And for people who needed to do online appointments, that was proving tricky. And so diagnostics were affected. From a surgical point of view, there was some plans to create some cold sites, to do urgent surgery in an area that they knew was COVID-free. The waiting lists, of course, the 18 weeks went up. Electives were pretty much cancelled. There was the issue of PPE, the surgeons trying to operate in really additional PPE than they were used to, and that sort of group is used to a lot of equipment, but really not able to do 6 cases a day because of that. Because of that requirement, and things like reconstruction were halted. It wasn't deemed necessary to be putting patients through these sort of surgical procedures when this unknown COVID was evident. From a chemotherapy, I'm sure there's lots of other things your own hospitals looked at in terms of how they modified services. From a chemotherapy point of view, we're a big cancer centre, an academic unit, and we decided in the morning that we were moving across the road to a private hospital, and we did it, and it's to our credit really that we were up and running by the next day. And I know many people took that approach, and others decided that they would split their hospitals into cold and hot sites so that they would be able to maintain a semblance of the service. There was instructions. I've got a couple of slides in a little bit. There were some instructions about stopping treatments, cutting short cycles, maybe 15 cycles instead of 18, about lengthening the intervals between cycles, particularly of the supportive care. So people on monthly zoledronic acid moved to 6 monthly, 3 monthly, whatever it was, a very individual patient need. Patients were put in holding patterns, so perhaps held on hormones whilst waiting for the pandemic to pass. Lots of conversations about moving to oral where possible from IV or subcutaneous from IV. Currently, we are still not doing scalp cooling. I don't know whether that's the same across the patch, but it's a massive issue for patients and for their psychological burden. So it is tricky. And of course, all the blue tech rules, all the rules around what order you can give regimens in, how long you can give them for, the intervals between, how long you can be off a treatment because of a toxicity. All those rules changed, and we were pretty much able to do whatever we were able to do. And there's some thinking going on now about whether those rules should stay or whether we go back to as was. And then from a radiotherapy point of view, there were shortened fractions, certainly reduced availability for palliative radiotherapy, often holding people on analgesia rather than bringing them in to have radiotherapy. And there were some approaches that, because surgery wasn't possible, then perhaps radiotherapy was the answer. And so in a sort of more proactive way that radiotherapy was used. So across the pathway, the pandemic has had an impact. And I think that's what we're starting to get to grips with now about how to move things forward. So these are some of the guidance that was issued. I'm grateful to Duncan Wheatley in the West Country for these slides. So in order to guide how to change practices, NHS England, in consultation with NICE and the Royal Colleges, came up with some guidance for cancer patients. So there was a real recognition that patients receiving SACT were a vulnerable population due to their immunosuppression, which we all know, but nobody sort of knew how vulnerable really. And so these guidance was put in place for the management. So particularly the MDT consultations and decision making should continue as normal. We're still a consultant-led service in treatment. Patients should be categorized by treatment intent and the risk-benefit ratio, and I'll show you a slide about how that was calculated in a moment. As I said in the previous slide, alternate and less resource-intensive treatment, so switching to oral or switching to subcutaneous instead of IV if possible. Using alternative methods to review people, so the rapid escalation in telephone clinics and video clinics have really been a benefit out of the summer, but also the collection of, having delivery services rather than bringing somebody in to pick up tablets and things. And of course, everybody should have a conversation and a risk balance consultation about what's the right thing for them at that time. So this is the sort of guidance that came out from NHS England. Again, this is another one of Duncan's slides. NHS England and NICE created this prioritisation categories for patients, and you can see their priority 1, curative treatment, curative intent. So those people that were really trying to cure, who would we would do them a disservice by delaying their treatment. Absolutely priority one. And so we go down the priorities until excuse me, until we get to those having less benefit from their treatment. So this was helpful at the time, and it was helpful in that organisations could all be sort of speaking with one voice, but it still meant that patients needed individual conversations to have that to get that expectation right, and to get everybody making sure that we were putting their best interests forward. So in terms of working differently in that way, as I said earlier, the cold sites were the way forward if at all possible. And we, as a treatment centre, are still in the private hospital at the moment, with a view to potentially coming back to the main site in January. And I know others in my region are still in the areas where they were. So perhaps in your areas you've started to migrate back to your host area. Certainly the development of telephone and video clinics has been a real advantage through the summer. As nurses, we were very much running clinics using telephone consultations, not so much video, but telephone consultations, particularly because we wanted to give people time back, which is a real benefit for patients. The time that they spend coming into hospital, parking, waiting in clinic, clinics are always running behind, for for a 10-15 minute consultation, and perhaps the carer that goes with them as well. This is things that time and time again patient surveys have said is wasted time for them, and when you've got a cancer diagnosis, you absolutely want that time back. So we had been doing telephone clinics primarily for that reason, but also because we had a real capacity issue, and the capacity was particularly in the waiting room. We had standing room only for patients to come in, and if people didn't need to come in, they didn't need to come in. So we had been doing it for a while anyway, but that has now widened to across the MDT, and the consultant body is doing virtual clinics across the board, really. We also had to think about, well, how were we going to new patients? How were we going to consent them? Because if we weren't going to see them, we were going to be on the telephone or on the video with them. How would we manage consent? Now, my centre, mostly nurses take consent through their pre-assessment process, but again, we weren't really doing that either. So how were we going to manage it? So again, with the approval of the colleges, there was a document written to say that we could do virtual consent, where a patient would be emailed the consent form. And I guess one of the advantages now is we have these national consent forms, don't we, that from CRUK, so it's easier, I guess. They were sent to the patient, and conversations would go on with the patient with that consent form in front of them, and they were either the consultant or the nurse's signature was either typed in before it was sent, and then the patient would bring the consent with them when they came for their first treatment. So it was a way to manage it, but what we also had to do was put in a safety net for that, because it is really difficult. Not all patients were seen on a video, and so trying to determine people's suitability for treatment when you can't see them, it's really tricky, isn't it? And so we put a safety net in on the cold site that every new patient would be seen by an ANP that was working on that site. And the reason for that was really to check that the consent was valid, make sure that the patient was indeed fit for treatment. We would be checking their doses, because we were relying on the patient to tell us their weight rather than us measuring their weight. And so just making sure their body surface area was correct and the doses was calculated correctly. Going through making sure their performance status was all right, going through, making sure they'd understood and they'd got all the AOS messages and things like that. And through the summer, we turned away, as nurses, 7 people who, in our opinion, clearly were unfit for that cycle 1 treatment. And I think it demonstrated that safety net worked. I particularly remember a patient who was due to have radical cisplatin with radiotherapy for a lung cancer, and clearly not fit for cisplatin. And so we then made arrangements to not give her treatment and have a face-to-face consultation with her doctor, and that was turned into carboplatin. So the safety net seemed to work. Now we are, for first patients, they are coming into the clinic to see the doctor for that first one, and then they would have everything else on the telephone. Excuse me 2 seconds. Sorry, I should have mentioned that I'm full of cold, so non-COVID cold, but full of cold. As well as that, we're working from home. So I'm at home today, mainly because I've got a cold, but I do clinics from home, and I am set up, and Captain Tom bought us all laptops and cameras and headsets and things. And we can now facilitate working from home really easily. I'm going to come back to that in a little bit. Some challenges in the beginning with Wi-Fi dropping out, and we have to tunnel into the hospital down a VPN line, and it didn't always work. And now it's much more robust. So working from home is possible and necessary now, I think, because hospitals being hospitals, with the social distancing that we have to do in offices and in the wards and in treatment areas and things, we just haven't got enough space to have that distance between us and have an environment that is conducive. The patient really believes that it's just you, the two of you, in this consultation, and not, background noise and other activity going on. So, but I'm going to come back to working from home because it is important, I think. Well, the things we had to contend with, and we're still contending with, is there's no visitors allowed in our hospital. There's no and the ward manager can make a decision that there is a special need for that person, and certainly end of life is one of those reasons. But in the chemotherapy unit, we've moved from being a very open plan area with allowing one person to attend with them, quite noisy, lively area, to everybody being in a pod in the private hospital. And that's good from a COVID point of view, of course, but it's very lonely. If you were, if you're a person having a BEP chemotherapy, for instance, you're going to be in that room 10 hours on your own, and some of them don't have TVs. The nurse will pop in every now and again. We can't create too many bubbles, and so it is different nursing and different ways of working. As well as that, the clinical nurse specialists particularly used to come to clinics to meet and greet people and be in the consultation when that was happening, or run their own consultations, wherever it might be. These clinics don't happen now, so there's no the nurses are having to work very differently, and currently we don't allow the nurse specialist to come over to the chemotherapy unit. So it's changing for everybody, and we really labour in our pre-assessment for chemotherapy. We really labour the value of the nurse specialist, but of course they're not meeting them as much as they would have done before. So that's a bit of a challenge. And then, of course, we've got the communication difficulties with the PPE. We all look at people's mouths, don't we, to hear, and that is quite challenging for patients and for staff. Initially we weren't asking patients to wear masks in the pods and things, but we do now, and we have a visor and a mask, and it is really difficult, and you find yourself trying to talk with your eyes and repeating yourself often, and it is a challenge, from all angles around that communication. We also know, and it's been borne out in evidence, Macmillan did a lovely survey mid-pandemic around people are frightened. And patients are frightened to come into the hospital, and they've lacked confidence that the hospitals are safe. And so us trying to get them back over the door, and attend AOS maybe, has been difficult. And there's been some campaigns, hasn't there, nationally and locally, to say we're open. People with chest pain not going to A&E because they're frightened of the COVID entrance and all that sort of thing. So I think it is important that we reiterate we are safe, we are open, and that we're here if you need us. My unit where I work and our acute oncology is supported by Macmillan. We are Macmillan badged and initial funding from Macmillan, and they are really, really struggling, as are all the charities. And I think May, June time, they put out a document which was called One Voice, and it was all the charities really sort of explaining their challenges through COVID. And I just read yesterday a tweet about Macmillan, 80% redundancies within their workforce. So this is going to have an impact on us going forward. The shortfall, it was millions, and so the smaller charities may well struggle with survival. And one of the other things I think is an advantage of the summer has been the wellbeing support that we've had. So I've already mentioned Captain Tom, who provided us with laptops and things, but they also refurbished wellbeing rooms, and all these things that hospitals should have, but actually don't. Every space is premium, isn't it? And so we've popped up some lovely timeout rooms across the hospital, and they are for everybody to use, and they have been a real hit. So working differently has been across the board, really. So knowing that we overplanned for COVID and that we reduced activity for cancer, that was all done with we don't really know what we're doing. We don't really know what the impact would be. And now we're starting to think about, well, what should we do going forward? And also possibly with a second wave coming, how are we going to manage services? And certainly my hospital has taken the view that we're not going to stop elective now. And we'll make decisions as we go rather than have this massive big preparation of wards sitting empty. So this, again, grateful for Duncan Wheatley for giving me this slide, which was about COVID-19 mortality in patients with cancer. Of course, we didn't know when we were making all these plans. And this was an observational study of 2 cancer networks, which included 55 cancer centres of patients who had cancer and symptomatic COVID-19 infection. And the interesting thing here was the increased risk of mortality from COVID-19 was to do with advanced age, male sex, and comorbidities, but not necessarily the cancer therapy. So this is the first, certainly UK study, observational study that we've had, that actually COVID didn't seem to be an issue for cancer patients just because they had a cancer label. They had to have these other things, advancing age, male, and comorbidities. So moving forward, that gives us some confidence actually that maybe we don't need to stop services. But we do know that a cancer surge is coming. Excuse me again. Because we've talked, haven't we, about the screening programs being stopped, people not going to their GPs or feeling that the GPs weren't open, and that now the campaigns around get yourself to a doctor, get yourself diagnosed, and also the advancing symptoms potentially, because cancer will continue to grow if not interrupted. So there is some thinking that there is a surge coming, and how are we going to manage that? So surge is used deliberately, as we talked always about the COVID surge. The cancer surge is coming, and I guess there's every other specialty is thinking exactly the same thing: colorectal, orthopedics, but we're concerned with cancer. So what have we been doing locally? And I'm sure some of your areas have been doing it as well. The government, NHS England, instructed the Cancer Alliances to come up with a plan for cancer. And particularly this slide is about cancer surgery. So if the surge comes, and actually, so I'm in Southampton, if suddenly we get 20 patients who need a thoracotomy, maybe not a gastrectomy, and it's urgent, and there isn't enough theatre capacity or surgical capacity, we can then take the case to a pan-Wessex cancer hub. So it's a virtual meeting really, and say, we've got this patient here, they need urgent surgery, we don't have the capacity to do it. And then from a Wessex point of view, so we are Southampton, Portsmouth, Poole, Winchester, Salisbury, who in that region could do this case for us? And they would then say, I've got the surgeon, I've got the anaesthetist, the patient can come to us. And so there would be no delay in that person having that particular speciality surgery. And so the case is sent from the trust to the cancer hub, MDT discussion, decision, there's capacity here, that patient would be informed and the surgery would be done in a different hospital. Now, that's taken quite a long time to get to, and actually at the moment it's virtual because services haven't really had that struggle yet. We've still got plenty of capacity in Southampton, and all the hospitals around us have still got plenty of capacity, so we haven't had this surge come through yet. And I guess that's because people are only going back to diagnostics and things as currently. So it will come. It's a little bit of a white elephant at the moment, or a virtual thing, because there is capacity, but there is some thinking, and as winter comes again, that we might need to implement this. And so with each, in order to get that up and running, there's obviously a lot of work up to do in terms of making sure that with the prioritisation of the patients was correct and adequate, that the operations were doable, and there's sufficient expertise around the area. Did the staff need to move to a different theatre, or how was it going to be pulled together? There's obviously lots of data flows we need to collect, how we were managing this, and of course we need to get some trackers and some exchange of information and exchange of money, in reality, because other organisations are not going to do work that they're not going to be paid for. So this is the framework that that we're working to, and that's been approved for the Wessex region, and every Cancer Alliance was asked to do this. Now, one of my projects in the Alliance was to do the same for chemotherapy or for SACT services. Now, straight away, you might be thinking, how on earth are we going to do that for chemotherapy? Because surgery is a one-off event, isn't it? And so the patient will go for the surgery, recover, and that will be it done. Whereas chemotherapy is not like that, is it? It's a program of care. There's cycles. There's pathways to consider. So much more complex, much more difficult to get a handle on. But we have come up with a working model. And really, this is not necessarily about the new patient that you can't fit in. This is potentially about if a workforce goes down. So we do know of two areas. One was in the West Country, where the chemotherapy unit had to shut because staff got COVID. And so across the board, the unit closed down, no treatment given. And we also know of a manufacturing unit of pharmacists up north somewhere, where 15 pharmacists were sent home because of the same reason. And so you can imagine these are crucial workforce, and so we can't maintain a service if you don't have the workforce. So should that happen to us, and I have to say in the chemotherapy unit where I work and the local ones, it's almost impossible to socially distance from your colleagues when you're in the treatment room, or when you're checking drugs, or whatever it might be. And so it is going to be, if one person goes down, we know we're going down. So this was really around if the host organisation identifies a problem and there were people who needed urgent treatment, how could we make it happen? So I don't know if you can see my cursor, but I'll use it anyway. So the host is here, and they would alert the Cancer Alliance panel. They would have a panel meeting based on this prioritization by the host. So it might be that there is just 6 lymphoma patients that really should stay on treatment, or there might be a brand new head and neck patient that shouldn't wait, because it's going to be time sensitive. Probably in 2-3 weeks that unit will be up and running again. So what is it? Not every patient. Some patients can wait. So what is it? What's the prioritization of those particular patients? A panel meeting would be asking at the neighbouring trusts, do you have any capacity to treat this patient for, how long? Maybe 1 or 2 cycles, maybe 3 cycles, or take over the care completely. The trust agrees. We are lucky in our region in that across the region, we have one prescribing system. We've all got access to it. Wessex itself, Dorset has a particular prescribing system. The 3 hospitals there all share. And then in what used to be called Central South Coast, we all have the same prescribing system. So you can access, one too many. You can access the patient details very easily from any hospital. So the trust would agree. They would then generate the prescription, referral made, the treatment would be given. Very importantly, the acute oncology needs to remain in the host organisation, because that's where the patient lives. So that seems to be important. And then really making sure we've got clear documentation in the prescripts of what we've done. And if the host organisation has any particular parameters that needs to be checked, that would all be done through the messaging system on the prescribing system. And then also over here, is there any possibility that this could be done at home? And if it's a yes, well, why don't we go to home? Remembering again, home care could go down with a workforce issue. If no, then if there's no scope, there's no activity at home care available, then that's a unique case. We need to make a specific plan for that. And then at the bottom again, there's a recharge of how we might exchange money. So how this would work in terms of the 2 ways that we're just discussing at the moment. One is that actually the host organisation refers to the organisation that is going to take up the case, and if they're going to take up the case in longevity, like do the whole pathway, then they need to refer to the oncologist in that particular area. So the oncologist can see them and takes responsibility for that particular treatment plan. If it's just that we're going to treat them with a couple of cycles, then we're actually talking about the patient just finding a venue to treat the patients, and the responsibility would stay with the host organisation, or the oncologist responsibility would stay with the host organisation. Of course, whoever treats them, there is responsibility for the nurse to do it correctly, and all those sorts of things. And very importantly here, we've got a separate slide which I haven't got, but is around capacity. Is not just about chair time, of course. It's not just about the nurse. It's how you get the drug. So what is the pharmacy capacity? And some organisations make on site, some buy it in. Some will have a bit of capacity, others won't have any at all. So it's a whole thing. It's much more complicated than the surgical hub that we talked about before. But this is the way that we're heading, and we hope we never have to use it, of course. But we don't know. We don't know. So moving forward, there is a view that we don't want to close down like we did before. We managed to only sort of avoid 25% of our normal activity. Everything else stayed. We were treating people, but we don't want to close down the hospital. And so there will be cancer diagnosis, there will be surgery, there will be then chemotherapy and radiotherapy. But these are the new things that we need to really be considering as we go forward. We've already talked about the virtual clinics and the PPE. The social distancing, potentially working from home because of space in the hospitals. The guidance is changing. We had a meeting. We had a presentation from the Prime Minister yesterday, didn't we? Which changes the guidance a little bit. We've got this new treatment guidance, whether actually we're going to revert back to treating everybody the way we did, because we understand COVID and cancer a little bit more. We've got winter coming, and I had my flu jab yesterday. Hope you're all getting yours. So there's lots to contend with going forward. Acute oncology, I think, is pretty sorted, certainly in my area, and the emergency departments are pretty sorted in terms of their entrances, the respiratory entrance and other entrances. And so I hope that will be, although they're going to be busy and overwhelmed, I hope their processes are sorted. We are going to have this late presentation that we've mentioned because people haven't been to their doctors. We've got the track and trace. Currently, at the moment, in my hospital, we as a staff we have a campaign that will be COVID zero as a hospital, and as a way to make sure there's no transmission in hospital, but also to so we can advertise to patients that there's confidence you can come in to see us and come into our hospital because we are COVID free. So we were all being swabbed once a week, and lots of obviously asymptomatic swabbing, and many negatives, and I started to feel a bit guilty about that, really, when you're hearing all these stories about people being sent, living in London, being sent to Newcastle because they can't get a test. And actually just this week our hospital has decided to stop routine asymptomatic testing, except for people who cross the barrier of the private hospital across the road. So from a chemotherapy point of view, the chemotherapy nurses will continue to have their swabs to allow us to work over there. But we have stopped it at the moment as a temporary measure to help out the scarcity of the testing plans. And then I just workforce there. Just this morning there was a report around nursing and being 40,000 nurses short. I mean, it seems every year, every couple of months we have this report, don't we? And we know, I read a report, I work at the university as well, and I read a report that they were, nursing courses were oversubscribed because of the good favour that we've been in through the pandemic, I think. But actually, it's going to take 3 years, 4 years, whatever it is, to train people. The workforce is short now. And so we need to make plans, and I'll come on to a little bit about that in a moment. So in order to take things forward, you may have seen these are just a couple of press releases around the outcomes being detrimental because people haven't been diagnosed, because people haven't been able to get to see GPs, because they haven't been accessing the hospitals. So remember that all our cancer policy is about trying to increase our outcomes, and to put us in line with the rest of Europe, because we know that the UK is doing better, but we're not closing the gap on survivorship and cure. So this report was around potentially an extra 20,000 people dying of cancer, which would be unnecessary deaths because of not accessing services. And then I don't put this up because Professor Peter Johnson works in Southampton. He's a lymphoma oncologist, but he's also the national czar now, and he's an all-round good guy, and he has been tasked with creating the task force that will lead to what are the changes that we need to put in place to make sure we don't get to anything like these 20,000 more cancer deaths. So I guess he'll be putting a group together, and I'm sure he's had lots of conversations already around how we move forward. So working differently, there are massive advantages to it that we've already outlined some. But actually, this is just some graphs that was put out this month by the Harvard Business School around, I mean, it's not rocket science, I have to say, but it is interesting. So the top graph here was around, we're sending far more emails, and we are copying in more people through lockdown, because we're not having corridor conversations, and we're not in MDTs, and so we're just making sure everybody's getting the message. And so that all that noise in your systems and trying to filter through your thousands of emails that you get if you take a week off, it's borne out. And this one is about meeting more often, but or involved in meetings more on Teams, but for less time overall. And then this one is interesting, I thought, which is about working from home and working remotely. And you can't really see this, I don't think, in yours, but this is like 10 hours. So people are working longer days working from home and working remotely than they would do if they were in the hospital. And so we're working harder, really. We think it's easy. We don't have to go contend with the traffic and do all this, but actually we're putting more hours in to get to the results. So yeah, just have a little think about that yourselves, and think if you notice that. Going forward, we know the workforce is exhausted. They've been dissipated as services closed down temporarily. People were redeployed, weren't they? And there's always this message about, we'll upskill people so they can work in critical care, and I really hated that. I don't think upskill is the right word at all, because actually everybody's got complementary skills, and just because I can't load a ventilator doesn't mean to say I'm any less skilled than anybody else. So just an irritation. But the staff were dissipated. They were working in different areas, in different teams, and that caused some problems for some people. We had a 1, 2, 3, 4 levels, and people were placed as appropriate. So that was quite difficult for some. We have to remember that some of the workforce were also shielding. So I was quite amazed how many really, really functional staff have difficult conditions to contend with, and yet you'd never know. I mean, I didn't know the details, but I knew they were shielding and actually doing really, really well despite the end of life team, palliative care teams, of course, dealing with things they've never had to deal with before, and really we've gone pan the hospital, really. As I've already said, we've been talking about recurrence of disease, and I'll mention that in a moment. Actually, the psychosocial impact on patients has an impact on the workforce, because people are isolated with illness, and so sometimes that can take longer. You can feel, as a nurse, you feel a bit more, I wish I could do more, and there was nothing to do. People weren't allowed to mix, they weren't allowed to do just even getting people's basic shopping was a challenge, wasn't it? So staff were overwhelmed, and of course all through the pandemic, and even in the last couple of weeks, the changing guidance, trying to get your head around the guidance as an individual, as a member of society, but also as you're talking to people in what they can and can't do. It's really difficult to keep up with it. And then we also had this campaign that we were, with the clap on Thursday, and we were all heroes. And most people in hospitals don't believe they're heroes. They think they're there because they want to do a good job. But that recognition, I guess, was nice. But when you're a hero, the only way is down, really. So we have to be ready for that. I wanted to just to finish up now, I wanted to say a couple of things about work-life balance. And As I say, I'm working from home today, and I'm fine with it. But I had a meeting with some clinical and specialist colleagues this week, and one girl told me a story that was quite harrowing, really. And she was working from home, and the reason she was working from home was because her son needed some surgery, and so she had to isolate in order for him to be able to be admitted to the hospital. So she wasn't ill; she was there because she was doing the right thing for her son. And so she was supporting her patients from home. She had a Captain Tom computer and her phone and things. But the conversation that she had with this young girl was about self-harm. It was about abuse. It was about suicide. And it was a dramatic story. And the nurse specialist was very able to handle that story, very able. But actually, it's a sort of story you take to supervision, because it was difficult. But actually, the memory of that phone call was in her living room, and so she was sitting on her couch with all her normal things around her, and as the work, the cancer, the drama of her everyday work life really entered her home life, and it has affected her. And I think we just need to be aware of that, and just to be cognizant of it. It's not just about I don't have to go through the traffic, and I don't have to get dressed. It is we have to be take things seriously. So it is we do need to make sure that we are looking after ourselves. And then, just this is my final slide, really, in terms of recurrence of disease, because people have had their treatments cut short, or because they've delayed going back to the doctor, they haven't opted in, or that late diagnosis because they haven't been able to access screening programs, or haven't gone to the doctor. This is going to happen, and one of the things I think is important is that, are we ready for that conversation? So we could argue that we're trained in breaking bad news. That we're trained in difficult conversations all the time, but actually this is a unique situation, isn't it? And I think we need some training on it. And I know there are some researchers in the University of Stirling, I think it's definitely Scotland, who are looking into that, talking to nurses at the moment, looking into, well, how are you going to handle that? How are we all going to be on the same page, no matter who has that conversation? So I think it is something that we really need to think about moving forward. So I think that was my last slide.
Hi, Elaine. Thank you. That was brilliant. Thank you so much for sharing your experiences. It's really insightful. So we have got a couple of questions, and please do keep them coming. We've got about 15 minutes to answer your questions now. So the first one that came in is, could you explain halting cycles and holding patterns, please?
Halting cycles and holding patterns?
Yeah.
Yeah, so halting cycles was really around patients who were perhaps on palliative treatments, or even adjuvant treatments as well. So as an example, in breast cancer, patient might have 18 cycles of adjuvant trastuzumab, and that would be their treatment complete. It would take a year to complete their treatment, and then they would be discharged and hopefully cured, and go into a sort of a remote follow-up pattern. But in the middle of the pandemic, there was conversations around, well, actually, do we need 18 cycles? That's the original trial that was done, that people would have 18 cycles. There was a trial that was done that said, that asked the question, was 9 enough, 9 versus 19? And it wasn't quite conclusive, but probably 9 would be okay. So those individual conversations went on with patients. So look, you're at 15 cycles now. To save you coming into the hospital through this pandemic, let's just stop it. So that's what I mean by halting cycles. In terms of palliative treatments, so there are some treatments that are, you keep going until you get disease progression, for instance. And people who were doing well on treatment, then a conversation again about, well, shall we put things on hold whilst we go through this pandemic, or what's your feeling about that? So maybe let's have a break now. And some of the rules around the drugs that can be used, like from the Cancer Drugs Fund, they very specifically said, if you have a treatment break, you can't then go back on this treatment. So if you're doing well on treatment, and then your doctor says, perhaps you get a toxicity, or perhaps you're going on holiday or something, and you want a break, the Cancer Drugs Fund rules would say you now can't go back on that treatment. And so from a patient point of view, that's pretty important, because that's the drug that was keeping them steady, and perhaps not curing them, well, certainly not curing them, but keeping them well. So if you stop the drug, likely that the cancer will start to escalate again, but you can't go back on that drug that was actually doing you well. So the government decided, NHS England and NICE decided that those rules don't apply. So if you think it's the right thing for that person to stop treatment through the lockdown, through the pandemic, then it would be okay to pick it up again when services were starting to build again. And what I meant by holding patterns really was my thoughts are around breast cancer, prostate cancer, whereas perhaps you would start with a chemotherapy drug or a particular drug, actually, in order to buy some time, which is an okay approach. They would perhaps give them some hormones, some anti-hormones, which would halt the cancer for a short period of time to allow the pandemic to pass, to then pick up with chemotherapy that might be have a better impact as it's gone. So that's what I meant by holding patterns.
Okay, that's great. Thank you very much. The next question is, can you please elaborate on your pods? We are having space issues, but SACT delivery nurses are keen to avoid pods as it reduces visibility of patients. Yeah,
so I couldn't agree more. You know, we've come from this very open plan area where nurses can visibly see, because nurses would start treating somebody, and then when the person was established and had their infusion going, they might then move on to another person, but they can still see that person. But now where we are, they are all very much in closed pods. You know, we can open the doors, but there's no glass to see through. We have one area, the private hospital has just moved a load of admin staff out, actually, in order to give us a bit more space. And we've been able to put 4 chairs in this particular big room. And we have put perspex dividers in between those rooms. So if the nurse is in there, she can see all 4 patients, or he can see all 4 patients. And it seems to be okay. And it seems to be, the patients seem to like it. It means they can talk to each other, because it's really lonely to be on your own, and you haven't even got family. And as I say, some rooms don't have TVs. So it changes the flavour of nursing, I think, because you can't, we don't have one-to-one nursing in chemotherapy, unlike, in ITU, where you could be, just looking after one person. You're managing several people at a time. And we all know there are, these are toxic drugs, and they can have infusion-related complications or reactions and things. And so it is different nursing, and I think you need to lobby for additional staff, even if it's I don't mean to be disrespectful, but I mean even healthcare assistants that can just go in, everything okay, whilst you're treating somebody else, because it's you just don't have that visual at the moment. And I think as we start to design new places and new spaces, we really have to take that into consideration.
Yeah, absolutely. So there is a follow-on question from that, which is, what was the distancing between your chairs pre and now during COVID?
Yeah, so we probably would have managed actually COVID distancing, COVID requirements. There was some low-level screens, opaque screens between a couple of the chairs, but in between each chair there was a table that was probably I don't know, about a meter, and then you've got the arms of the the chair. So I think probably from a distance point of view we would have been okay. Maybe taking one out would have created the same distance that we have now. But when you add in all the nurses and all the the through traffic and the equipment and things, it was quite a busy place. And also the entrance to our particular unit was through the outpatients department, so you'd be walking through a crowded waiting area. So it is difficult. It is difficult.
Yeah, absolutely. Thank you. So the next question is: are you screening your staff for COVID?
So we were all staff across the board. We were having weekly screening tests. We could turn up and somebody would do it for us, or we could self-do it. And I've done all 3. When I've done both. Really horrible tests. I'm sure you've all had them, but horrible test. When it came to the self test, I don't think it's possible, but certainly not for me, to get to the right place, because you just stop it, because you don't want to hurt yourself, you don't want to gag. And I did one, and I got a result back saying it failed because they just hadn't picked up enough cells. And then I've done another one that said it was fine, but it's just stopped this week because of the testing issue, the lack of resources for testing. So we are exempt from that in chemotherapy because we have to cross over the pathway of the private hospital. So I had one yesterday, Monday. I haven't got a result yet, but it'll likely come today.
Yeah, perfect. Thank
We're testing patients, though, all the patients. Sorry, I don't think you asked about patients, but all patients are screened, have a COVID test the day before they come in for surgery, diagnostic, or chemotherapy. And so if you're on a weekly treatment, or if you're on a day 1, day 8, day 15 treatment, you're having that done every week. And it just lengthens the process. We know we need a blood test, we need a COVID swab now, we need the review, then they come in for their treatment. It's like a 4-day process now. And it's just, patients are very accommodating, but it's just adding to the burden of having chemotherapy, I think.
Yeah, absolutely. So the next question is, do you have any links for Captain Tom's charity so that we can obtain a laptop and headset for our oncology team? We've made the request, but obviously the trust has been overwhelmed with requests, so any other avenues to explore would be greatly appreciated.
Yeah, I don't know how it worked, actually, because the trust was given wellbeing money, and we were told that was Captain Tom's money, and the trust chose to buy laptops and headsets and refurbish these wellbeing rooms. So I don't know how it worked before it got into the trust. The trust made the decision that's how we were going to do it. But I would make the case, excuse me, I would make the case with your, whoever's, that if they want you to work differently and want you to work remotely and they want you to work in a distant sort of way, these are essential. You have to be kitted out with the equipment that you need in order to do the job. And actually, I have to say, the headset I've got on now, it's really robust. It's really, we've been using them a lot, and we're throwing them on the desk, and they are getting bashed about. But actually, they're very good. The computers are Dell computers, and they're very basic. They're a bit tinny, but they absolutely do the job. And so I would lobby for it. Just lobby with your managers, and if you want us to do this. The avenues that we had previously around the charities, I mean, they're just not going to be there. They're just fighting for survival. So yeah, and you can't even share, so because of COVID. So we all had to be kitted out with our individual laptops, our individual phones, individual headsets, and so it's a big undertaking, but it's not like you can have one per team or anything like that, because you've got to disinfect, and of course headphones, you're going to be spitting into it all the time, aren't you? So you don't want to be sharing that at all.
All right, perfect. So next question is, there seems to be growing anger in the cancer community around treatment delays and deaths during COVID compared with COVID deaths. When we're talking about difficult conversations, how do you think the best way to deal with it is? Should we be focused on highlighting that we are open for business?
Yeah, I mean, I think you're right. There's, I mean, the media's really picked up on, haven't they, around delays in diagnostics and delays in treatments. And I think, those sort of campaigns, that's nothing that we don't know, but of course people who are not involved in services perhaps don't know, and there is some real proper anger. To be honest, I don't know. I think honesty is all we can be with patients around the way things were handled and the vulnerabilities that were known at the time, and reassure them that the treatments that we're going to give them are appropriate treatments. And it's that crossover, isn't it, between what would have been curative and what is not now curative. Doesn't mean to say it's very palliative right now, but it just means it's not curative, and that is a really, really difficult conversation. I know I've had a career in cancer care, and I am a big fan of cancer patients. They are massively resilient, massively they get knocked back, bounce back, get knocked back, bounce back. But I think this is, well, globally it's going to be a challenge, and I think we probably will get some guidance about how to do it. So I would talk to your medical colleagues and make sure you've got the the position correct in terms of what do you think of this, just so that you're not contradicting and things. And as I say, this research that's going on now is trying to come up with a toolkit or a suggestion really about how to handle these sorts of conversations, and be confident in yourself in terms of you handle difficult conversations all the time. And as individuals, we've probably got family members that wider family members who are in exactly that same position, so you can have some empathy with your patients at times. So yeah, I've got no magic answer.
Thank you. So we've got time for a couple of more questions. So we have got two. So we'll answer those and then leave it there. So the next one is, how do you ensure that your patients are safely assessed in a virtual clinic prior to SACT? Our team are undertaking telephone reviews prior to treatment, but I have found that there are more patients attending for treatment and having to be delayed as they have symptoms they didn't express on the telephone review.
Yeah, really difficult. I think it's really hard if you can't see somebody. So if they're trying to describe a rash, or you get so much, don't you, from just that visual. When they used to walk into the consultation room, you'd pick up so many cues just in that, and you're not seeing that, and you don't know what they're not telling you, and you don't know who else is in the room. That I did read some disturbing commentary around people being coerced in their own home, that they wouldn't necessarily, because you can't see the other significant person, pushing them towards treatment when actually they didn't feel like they were fit enough for treatment. So it's wider than just talking to that patient. So I think we need to trust the nurses that in the treatment room. If they are not fit, they are not fit, and so we need to support them to make that decision. I think we have a toxicity-based assessment, and so we try and do it in a very sort of conversation-like way to try and ascertain what's been going on with them. But sometimes you've just got to be very targeted based on what their drugs are. I spoke to a man last week who had a week off because he'd had a urine infection, and he was much better, only a youngster, much better, and I know him very, very well. And he was really keen to get back on his treatment, and he was at work, and I thought, all these sort of things are coming into place. And he was due to have treatment on Tuesday, so we agreed all that. His bloods were okay. And then the treatment nurse rang me a couple of days later to say, did he tell you that he's having a prostate biopsy on the Wednesday? And I'm like, well, no, he didn't. And actually that's quite important, considering I was going to give him, big dose chemotherapy the day before. And there was no documentation around it. And anyway, we had the conversation, and she delayed him till a couple of days later. But so I guess you can only do your best. But I would really rely on the treatment nurses. If they're the last person that is going to stop that person having inappropriate treatment, aren't they? And so if they're not fit, they're not fit, and we need to support them in and maybe the follow-up is around, why didn't you tell me about that when I spoke to you? These are the sort of things that we need to be talking about, we need to discuss. So it's all learning.
Absolutely, thank you. So the final question is, could you share this study that gave evidence about chemo treatments being safer than we had first thought during COVID?
I can, but I will have to look it up, because I cut the bottom off in order to make it fit on the slide. So
we can send it around in an email after.
Okay, yeah, it's I guess there's an acronym on the slide that maybe if you even put that into Google, you'd find it. But I'll look it up at the bottom, and I'll perhaps give it to you, Hope. Yeah, and you can put it in. Yeah, absolutely. Okay, yeah. If anybody knows Duncan Wheatley in Devon, I think, or Exeter, then he provided that slide. So if he's in your locality, go and ask him.
That's great. Well, thank you very much. That is all we've got time for today.